Hello friends, in this discussion we will see what were the questions asked for our last FMGE examination July 2023. Talking about the exam paper as such, Anaesthesia had good number of questions and most of the questions were repeat. We don't have any a very tough questions in that kind, but all the questions was bit of a tricky in nature. Anyway, if you have gone through the notes, you will definitely get it very easily. So we will see one by one what were the questions asked. See, the first question is, which is a muscle relaxant which undergo a Hoffman elimination? We have seen enough and more time that this question has been repeated, and it is that whenever you hear about Hoffman elimination in anesthesia, there are only two drugs which come to your mind. They are, one is atracurium, and the other one is cisatracurium, isn't it? So in this question they have clearly mentioned that cisatracurium is there in the option, so we have no doubt about this. Okay, so although we say atracurium is so much associated with Hoffman elimination, there is a significant amount of ester hydrolysis happening in this molecule. Same with cisatracurium also, but for entrance purpose, remember Hoffman elimination and atracurium and cisatracurium as related. Okay, now talking about other drugs, say for example mivacurium, this is basically eliminated by pseudocholinesterase, just like scoline. This is an important area which they have highlighted, because these are the two muscle relaxant which get metabolized by pseudocholinesterase. One is choline, second is mivacurium. Remember that. This is very important. This has been repeatedly asked even for INICT examination also. Okay. Now, vecuronium. Desacyl vecuronium is the metabolite which actually metabolized by liver and get excreted through kidney. So it has got the metabolite itself has got around 80% of the property of vecuronium. So that is why we don't give vecuronium for patients with renal disease. Okay, so that you know the mechanism. And rocuronium, that is also a wonderful molecule which doesn't metabolize at all, which get eliminated without metabolism, without a metabolism. So that is, so in talking about this question, this is a wonderful question which they have framed, and it is, although it appears to be very simple, it's very tricky. That this is a sequence of questions we had this time, and probably the next question is even more tricky. Okay. Now see, the question here is, what is this classification known as? Question number 2 is, what is this classification known as? We have seen enough and more times the question has been repeated about, whenever you think about assessment of the Mallampati airway, Mallampati comes to your tongue. So Mallampati assessment is probably the best assessment, or the which has stood the test of time. Although many assessment came in, but Mallampati remains the same. So we are all very familiar with Mallampati classification, where you sit very in the same level of the patient, ask the patient to open the mouth, protrude the tongue, and ask them to not to phonate. Ask them not to phonate. Okay, so that is very, very important. Here, tongue has been protruded, nothing has been mentioned about phonation. So it is, if that is a question, it is clear. Mallampati is a clear answer for this question, because a mouth has been opened, tongue has been protruded, patient is in the same level, that we presume. Okay, so answer here is Mallampati in that way. Now suppose they have come up with a bit more tricky in nature, then this could have been another way. Maybe there could have been a recall error also, where the tongue has not been protruded. In that case, the picture look almost the same, except for the fact that the tongue is not protruded. In that case, we call it as Friedman classification. We will see the other classifications also. So as you all know, Mallampati 1 and 2 is considered as easy intubation. It is easy, while 3 and 4 is considered as a difficult intubation. This is something which everybody knows by this time. Okay, so remember this. Now please see Cormack and Lehane classification, and this also we have discussed. Cormack and Lehane, although it is a classification of the airway, here we classify after paralyzing the patient and doing a laryngoscopy. That is a difference. While Mallampati happens in the office room, while Cormack and Lehane happens during the intubation, just before intubation after the laryngoscopy, and how you visualize the vocal cord. See, in that case 1 and 2 is considered to be an easy intubation, while 3 and 4 seems to be a difficult intubation because you don't see the vocal cord at all, you don't see the glottic opening. Okay, so that is Cormack and Lehane classification. Now coming to the other options given in this is the one which they said Friedman classification. I don't think they would have gone to this extent of asking Friedman and confuse you. It is probably a Mallampati itself is the answer. Now if at all they want to ask that question, then Friedman, how do you differentiate? The simple answer is, in Friedman classification, it's the same. Patient is opening the mouth and sitting at the same level. The tongue is not protruded and the patient is phonetic. Tongue is not protruded is a characteristic catch point in this assessment. So as you can see, the tongue is not protruded. Some figures also mention the presence of small incisors here. In that case, it becomes very easy because that interns tell you that tongue is inside. But anyway, the concept is to be very clear to you. If they can ask this question as a repeat, then remember about Friedman classification also. This is usually done in OSA assessment and tonsillar position and things like that, which is entirely not a part of anesthesia. Probably your ENT teacher will discuss more about this. Okay. Now, Brodsky's classification. Brodsky's classification is the next one, which is again the tongue is protruded. It is used to assess the tonsillar size and assess significance of tonsillar hypertrophy and things like that, which has nothing to do with an airway assessment. So that is also another score which you can remember, Brodsky's score. So in this question, they have given 4 concepts for you to remember, 4 classification to remember. So this is a very informative question for you. Okay, I hope this recollection will definitely bring you a new piece of information. Okay, coming to the third question, here the question is, which is a benzodiazepine antagonist? In this case, we should know what are the drugs given. See, flumazenil, naloxone, sugammadex and atropine. These are the 4 drugs. Flumazenil, as you know, it is a benzodiazepine antagonist. This is the benzodiazepine antagonist. This is a very common repeat question which has been asked many times. Benzodiazepine antagonist, flumazenil. Okay. Now, the next one is naloxone. Naloxone is an opioid antagonist. This is also a repeat question which has been asked multiple times. So, I hope you will remember this. Naloxone and flumazenil. Okay. Now, third one is sugammadex. Sugammadex, as you know what is sugammadex? Sugammadex is actually an antidote, or you can say it is a reversal agent for rocuronium, as well as vecuronium. Okay, so sugammadex is an agent which actually mixes with rocuronium and vecuronium and then eliminate them. So it is actually an antidote, something like a reversal agent which mix at a ratio of 1:1. Remember that 1:1. Okay. Now the next one is atropine. As all of you know, it is an anticholinergic agent which crosses the blood-brain barrier, and that is why it is used in the treatment of OP poisoning. And atropine, as you all know, it produces more of tachycardia, less of drying up secretions, and you compare it with a glycopyrrolate. Clear? So that is a very simple question. Now, next is again a repeat question. It is Tuffius line. So, as all of you know, most of you would have gone and done a spinal. In that, how do you identify where to give a spinal? It is by palpating the superior crust, superior iliac crust. A line which passes through the superior iliac crust is known as Tuffius line. Now, this line actually cut through the intervertebral space of L4 and L5 in most of the cases. To be very precise, it is the lower end plate of lower end plate of L4 in adult males and upper end plate of L5 in adult female. Even if you recollect that it passed through the intervertebral space of L4 and L5, that is perfectly okay. Okay, so remember this. This is a very simple repeat question. Okay. Now see the next question. This is the question which I wanted to show you. This is the Tophius line which has passed through the L4, and it is the superior iliac crust. Okay, it is not anterior or posterior iliac spine. It is a superior iliac crust, the uppermost portion of the iliac crust. That is the most important point to remember. Please see, this is again a very simple question. Which of the following is the choice for as a fluid during a surgical period? Now, as you all know, we have seen many times that how do we classify IV fluids. You can classify IV fluids broadly into crystalloids, colloids, and then blood and blood products. Okay. Now there can also be artificial blood substituents which doesn't come into the purview of our discussion. Anyway, what is important is this: they have asked a very simple question: what is the fluid which you use for during the surgery? Now it is very simple. We have 3 or 4 types of crystalloids normally. The most commonly used ones are ringer lactate, normal saline, 5% dextrose, DNS. As all of you know, these are the most commonly used crystalloids in our clinical practice. So ringer lactate is mostly isotonic, very closely related to ringer lactate. The other name is, or something associated with, is called the Hartmann solution. It is the most physiological, or which is having an osmolality very close to the physiological osmolality. So that is why this is called almost isoosmolar solution, and that is why this is used as a maintenance fluid during surgery. This is also used as a fluid for preloading the patient also before we give spinal anesthesia. So most of the time this is the fluid which we use. Okay. Now normal saline, although you call it as normal saline, it is not normal because it is not very commonly administered, because there is a significant change in the osmolality and electrolyte abnormalities which can happen, and too much administration of normal saline can cause metabolic abnormalities also. So we don't use it very often, except for the case that we want to increase the blood pressure significantly, and if you choose a crystalloid for that, then probably normal saline has got an upper hand. That's the only option where you think about normal saline. Too much administration we don't perform because it produces metabolic acidosis later. Now 5% dextrose is practically useless nowadays. We don't use 5% dextrose because it doesn't actually go into the vascular compartment, because the moment 5% dextrose enter into the system, dextrose is metabolized away and it is free water which actually goes to the tissues and produce more of a tissue edema, doesn't stay back in the vascular compartment. So we don't use, especially this is not to be used, it's contraindicated whenever you're doing a CNS case or a head injury patient. Similarly is the case with dextrose normal saline. If you most of us think that okay, we should supplement some amount of glucose and give dextrose, but that concept is already gone, and we don't use DNS or 5D to supplement dextrose or energy to the patient. A new one which has come up is plasmalite, which is actually more isoosmolar to the body fluids, and that is the one which we use for transplant surgeries and large volume transfusions. Okay. Now then you will think, when do you use colloids then? The only use of colloid is to bridge the gap between getting the blood before the patient goes for hypotension. Suppose you have a patient who is actively bleeding and it takes some time for the blood to come, then during that short period, in order to maintain the intravascular volume, we can use colloid. Otherwise, it is always crystalloids. The 4 crystalloid which we have mentioned is always the choice. Now, colloids also, why it is not very commonly used, although it was very popular during the olden time, it is not used nowadays because it has got a lot of problems like allergy. It can produce hamper with the coagulation system of the patient. It can produce microvascular issues and many other problems associated with that. So that is why colloid is not used nowadays, especially patient with renal and hepatic problems. So finally, we reach blood products. Blood and blood products are the best fluid to replace any loss of intravascular volume. So if blood is lost, then Paxil is the option. If the coagulation is a problem, then FFP is a choice. And if platelets are down, then probably platelet transfusion is the best. And if fibrinogens are less, then cryoprecipitates are the choice. This is how you administer IV fluids, crystalloids and colloids in a patient. And how do we select this? I hope this will give you a general idea to attempt such question. Anyway, coming back to the question, this was a rather very simple question. They asked which is a fluid they use. Some questions was recalled like whether it is, they just mentioned crystalloids. Some people have given about normal saline and ringer lactate. Now you know crystalloids are a choice, and of the crystalloid, ringer lactate is the best. Okay, I hope the point is clear. Now coming to the next question, which of the following is not used in ACLS? Okay, now here ACLS has been repeatedly asked. As most of you know, one or two question usually comes from ACLS in FMGE exam. Okay, so this time they have asked about drugs. Usually they ask about the compression, ventilation ratio and things like that. This time they have asked about the drugs. Now coming back, we'll see the options. High voltage defibrillator, you know that is probably the best option. 2020 guidelines, early defibrillation is a choice. So defibrillation is definitely there, no question about that. Now coming about the drugs, these are the three drugs available, of which we have studied that adrenaline is the drug of choice in any case of cardiac arrest. Okay, now see, when do you choose adrenaline? For that we should know, when you go and collect an AED, there can be two kind of rhythm. One is a shockable rhythm or a non-shockable rhythm. If it is a shockable rhythm, directly give defibrillation. Now, what are the shockable rhythms? It is ventricular fibrillation and pulseless VT. Isn't it? Pulseless VT. Now, which are the non-shockable rhythm? It is pulseless electrical activity and asystole. Isn't it? So, pulseless electrical activity and asystole are the non-shockable rhythm. So, whenever you have a non-shockable rhythm in your monitor, then what you do, this is the guidelines they say. This is a typical term they say, ASAP adrenaline. That means administer as early as possible adrenaline. So, you know adrenaline is a choice. It is given at a concentration of 1 in 10,000. 1 milligram administered and a concentration of 1 in 10,000 concentration. Okay, this is how adrenaline is given. Now, then you continue with CPR and then give and the cycle follows. Now, if it is a shockable rhythm, they shock, and after the shock of 2 minutes of CPR, after 2 cycles, then also adrenaline comes into play. Okay, and after two shots of adrenaline, if you want to think about another drug, then probably the next one is amiodarone. Amiodarone administered, this is the second drug which we use. The dose is 300 milligram bolus followed by 150 milligram as an infusion. Okay. Now, if you have no amiodarone and if you want to try a third drug, then probably the third drug what we use is lignocaine. Lignocaine at a concentration of 1.5 milligram per kilogram. So these are the drugs which we use in ACLS. But in all this discussion, we have never discussed about sodium bicarbonate. Because why sodium bicarbonate always come to your mind is in earlier guidelines, there was sodium bicarbonate. Whenever you think that there can be an acidosis, there can be a cardiac arrest and there is poor perfusion, they think that there will be lot of peripheral pooling of blood, and peripherally there will not be elimination and there can be acidosis, and to correct this acidosis we have to give bicarbonate. That was an older thought. Now we don't believe that. Now we have to improve the cardiac output, improve the perfusion, and naturally subsequently when you get an ABG and you think the ABG has got an acidosis less than 7.25, then only you think about adding or giving bicarbonate, and it doesn't come in the purview of ACLS. I hope the point is clear. Now, the next question, what is this needle? This needle is, although it is not an ideal anesthesia question, since the other options given in that come into the purview of anesthesia, I thought I will discuss this. From this needle, you can very well see there is a small tap and there is a small vent to which you can administer air or carbon dioxide. And then there is a small closing thing, and here you can put a trocar also. So this is essentially a trocar and it's called a Weiss needle. Weiss needle is basically used to create a pneumoperitoneum. Okay. Now, discussing more about these needles, we have already seen a Weiss needle. Tuohy needle is the one which is very commonly asked by them. Tuohy needle. This is the Tuohy needle. This is essentially an epidural needle. Epidural needle, and Tuohy needle is identified by gradations of black and white gradations, and it has got a stillet. It's here. This is the stillet, and there is a curved tip. Okay, so these are the 3 points which you can help to diagnose a Tuohy needle or to identify a Tuohy needle. Okay, now spinal needle, the commonest name of spinal needles is Quincke-Babcock, as all of you know. Quincke-Babcock needle is the most common. Most of you have done. The blue color is a 23 gauge spinal needle, which is an example of cutting type of spinal needle. Clear? So these are the questions which they have asked about that, and we have one more question which has also come into that. In this case of maxillofacial trauma, which is the best method of securing airway? Maxillofacial trauma airway is a very, very challenging thing for the anesthesiologist. I can explain to you the option C. I can explain to you better with a X-ray image. But before that, just see the options. One is orotracheal intubation, our normal route. Another is nasotracheal intubation. Third is an LMA, which is a supraglottic airway. And fourth one is tracheostomy. All of you know the answer is tracheostomy. Why? Because orotracheal intubation, it is performing with a mandibular fracture. Scopy seems to be very, very difficult, isn't it? And nasotracheal is absolutely contraindicated. Any head injury, any condition where you think of a posterior fossa injury, nothing through the nose. That is a dictum. Okay, now LMA is out of question because the biggest problem with such an injury is the blood will be aspirating and patient will be unconscious, and the biggest side effect of LMA is aspiration. So you should not think about LMA at all, because the LMA will cause aspiration, and these patients are notorious to have an aspiration because they have a facial injury. Sometimes they may lose consciousness, so these blood will go in directly into their lung and produce aspiration. So the best thing, you want a definitive airway which go and occlude the entry of blood and other secretions into the trachea, which should be accessed below the site of injury. This is essentially tracheostomy. This will become more clear if you look into this X-ray picture or the MRI picture which is recreated. In this, you can see in such an injury, you have no scope of putting an a nasotracheal or an orotracheal intubation. Okay, you have only option is to go through the tracheostomy. I hope this is very clear from this picture. Okay, now please see the last question, which is the air is used in, which of the following is used in the laparoscopy? That is a question. So they asked whether it is carbon dioxide, or the air, or the nitrous oxide, or oxygen itself. All of you know that in India, on most of the part of India, we perform laparoscopies by administering carbon dioxide. The biggest advantage being it is not inflammable, it doesn't interfere with the cautery, and it is freely available, cheap of course, and it is actually inert. Most of the time it is inert. The problem is that too much of carbon dioxide, too much performed, can go into the can have an absorption into the patient's body, and that can have problems. That is the only issue. Otherwise, most of the time we perform laparoscopic surgeries with carbon dioxide. Oxygen is not very much used because of the problems of it helps in combustion. Nitrous oxide, of course, not into any closed chamber because it will swell up in any closed chamber. So nitrous oxide is absolutely not used. Okay, so carbon dioxide is your best option. Air as such is not used because we don't have a mechanism to administer air, while carbon dioxide is available freely in gray color cylinders. Okay, and these are the questions which we had in our recall session from the various recalls we had. And I hope this discussion will be useful, and most of the questions were all repeats and very easy, except for a few tricky ones which challenges your thinking process and your ability. This is actually a very motivational kind of question paper. They have actually come up very much in the standard of FMGE, and I hope all of you will do good. Okay, thank you.